We've heard so much about vaccines the last few years, and I feel like we're all just overwhelmed with talk of the COVID vaccine and sometimes forget that there's a lot of other vaccines that are being researched and studied and implemented, not just here in the US, but across the world.
Right. And our changemaker today is really heavily involved in a lot of vaccine development, particularly in developing countries all over the place.
There are vaccines that we probably take for granted, and our guest today can talk a lot about those and interesting areas of the world that you might not expect her to be. Her name's Dr. Karen Kotloff from the University of Maryland School of Medicine. We talked with her remotely, and which is appropriate considering she finds herself in sub-Saharan Africa, in Bangladesh, you name it, she's probably been there.
She is all about that global health and making sure that people from all over the world, all different cultures, have the right access to live the healthiest lives that they can.
You're listening to the heartbeat of the University of Maryland, Baltimore, the UMB Pulse.
Joining us today is a changemaker with an incredible story. She is a pediatric infectious disease expert at the University of Maryland School of Medicine, where she is both a professor and the head of the infectious disease and the tropical pediatrics department. She's also the associate director for clinical research at the Center for Vaccine Development and Global Health and a fellow of the American Society for Tropical Medicine and Hygiene. She is the principal investigator of 4 grants funded by the Bill and Melinda Gates Foundation, studying the prevention of death among infants and children in developing countries, and the principal investigator of a National Institute of Allergy and Infectious Disease funded vaccine treatment and evaluation unit. And last but not least, she has published more than 200 manuscripts in peer-reviewed journals. We are so happy to be speaking with this changemaker today. Please welcome Dr. Karen Kotloff.
Well, thank you so much for having me, Jenna.
Yeah, we're very excited to have you here today.
So, Dr. Kotloff, you have accomplished so much in your career. It's hard to pick a starting point to have our conversation. Before we jump into the specifics, do you mind giving us a brief summary of the work and the research that you do?
Sure. So I have 2 lines of research that I do. One line as the head of the VTEU, the Vaccine and Treatment Evaluation Unit. I conduct clinical trials in all age groups in the US and abroad. And the purpose of that grant from NIAID is to try to develop vaccines that may be impeded for some reason, that there's maybe not commercial interest because these are vaccines that help people in developing countries, for example, or vaccines that are responding to a public health emergency, such as COVID. So that's one of the lines of research that I do. And the other is to do work in developing countries. And in developing countries, I try to prevent infectious disease and infectious disease mortality by studying the burden of disease, trying to find interventions that may decrease that burden, measuring the effectiveness of those interventions, and then trying to get interventions that work into public policy.
Great. So as you mentioned, a lot of your work is centered around global and public health. Tell us about some of the steps involved to handle a public health dilemma.
Sure. So we know from some of the global health statistics what the major causes of mortality are among children. So we understand that diarrheal disease, for example, is one of the major killers of children in developing countries, whereas in wealthy countries, such as the US, these diseases are minor illnesses that children easily recover from. And I have devoted a lot of my career into understanding better what causes diarrheal diseases and why they adversely affect children's health. So, for example, I helped to lead a study that we called GEMS, the Global Enterics Multicenter Study, where we went into 7 countries in Asia and Africa and recruited large populations of children with diarrhea and healthy children, and tried to understand what the major causes, the major viruses and bacteria and parasites that were causing these diseases. And then we followed up these children to try to understand what the consequences were, whether children recovered from these diseases, how often they developed persistent diarrhea, what the effect of their illness on their nutritional status was, and finally, how often these were deadly diseases and which were the major pathogens, the major germs that were causing bad outcomes. That study really was very informative to understand which of the germs are most important to direct interventions against. And so, for example, what we found is that the children with diarrhea over a 2 to 3 month period had an 8.5-fold increase in mortality following an episode of diarrhea requiring medical attention. And we also found that following an episode of diarrhea, they stopped growing for a period of time, that they were under observation. And so the children who survived had adverse nutritional consequences. And we learned what the major causes were. And so these findings helped to direct interventions. So we learned a lot about the major bacteria, parasites, and viruses that were causing these severe illnesses. And that helped to understand what agents should be targeted for, should be prioritized for vaccine development and maybe drugs or other appropriate interventions. And we learned that there wasn't enough attention to children's nutritional status when they had an episode of diarrhea. And we actually now have some interventions to try to improve the nutrition of these children when they have severe disease. So severe diarrheal disease. And so those kinds of studies teach us a lot about interventions that are needed. And then there's a whole number of follow-on studies that are going on to try to develop vaccines now against the major pathogens. We're participating in a study with the World Health Organization on nutritional interventions. And so it really helps to guide kind of the next era of research to try to find ways to improve children's ability to survive in a healthy way these types of infections.
I really put some of that in perspective. Didn't, think about diarrheal diseases and that frame, when it comes to growth and development. But you mentioned your work in Africa. Let's kind of zone in here. What countries or what country in Africa is your work based in, and why that location?
70% of children who die from diarrheal disease are living in sub-Saharan Africa and South Asia. So if we're trying to understand this problem, that's where we want to go. And because of weak infrastructure, that's where the least amount of information was coming from. And so that's where we went for this first study. We were in 4 countries in sub-Saharan Africa and 3 in South Asia. So I got a lot of frequent flyer miles during those years. And we set up sites that were population based. So we went into areas and got a census so that we could really understand what the numbers meant that we were getting by anchoring them within the population. If there's 100 deaths, but you don't know if that's among 1 million children or 110 children, it means something very different. And so we worked in census populations in these areas to do these studies. And you go where the problem is the worst to try to fix it.
So what's it like working in those developing countries? If you can maybe pick out a couple of them, but I also imagine at the same time, the cultures are so different from country to country in sub-Saharan Africa. What's it like living there and working in that environment?
So for me, it's just absolutely fascinating and gratifying to work in other areas, and it's very different as a tourist to travel an area and to work in an area where you really get to know people, you get to know their families, where they live, you make connections and engage with these people. Um, and I mean, in any environment, that's the gratifying part of work that we do when you enjoy working with people. And learning about similarities and differences in a group that is working together for a common purpose, for me, is just one of the most gratifying things that I do.
And Karen, what is the surroundings like there? We're used to Baltimore where we're recording. Give us a little picture of what it actually looks like there.
Well, it depends on where you are. So I was working in one area, which was a rural area outside of Dhaka, Bangladesh, called Mirzapur, where, as far as you can see, there were fields of mustard plants with yellow flowers and rice paddies with what's the name of the buffalo? And rice paddies with water buffalo pulling along plows. And we were riding in a car, and it was the end of rainy season, and we got stuck tire deep in mud. And the villages were just really, it was just a bucolic environment, just a beautiful place to be. And what you also learn when you go in these places is that how resilient people are, that people are happy with what they have, with their families. I mean, there are so many shared values of what's important, and it doesn't matter how much you have. There are some people who don't have enough, no matter how much they have, and there are people who get happiness and appreciate what they have, even if it seems minimal to somebody from another culture. So that's one environment. In Africa, we were in 3 rural and 1 urban area, and it's almost the same themes. I mean, the rural areas for me, looking at the straw huts and just going across the countryside, is absolutely beautiful. And then the bustle of a city is beautiful. And then the way that you see people making do with what they have. So you can see somebody riding a bicycle with 25 straw roofs on the back of their bicycle, and a husband and a wife in the front. I mean, it's just amazing how people make do with what they have, and how creative they are. And that was also a part of life that I really enjoyed seeing.
Well, and you work primarily with children. So in the early days of your work, what happened when a child was taken to a hospital? It sounds like a lot of these rural areas, a hospital would have been hard to come by. And then the treatment there, how did a child fare when they went to the hospital?
So the first place I worked was in Bamako, Mali. And going to that hospital honestly just makes you cry. Children come in, there's an insecure source of oxygen. There may or may not be IV fluids. They may have to pay for any treatment they get before they receive that treatment. and the mortality of children coming into that hospital is 20%. And it's heartbreaking because they're dying from diseases that barely affect children who are well nourished and living in clean environments. And it's almost easy to understand some of the solutions because the solutions are already being executed in countries that can afford them. And the goal is to speed the introduction of those same vaccines and other interventions into use in these countries.
Well, speaking of introducing vaccines into these countries, you, in doing so to address these health concerns, you had to create a vaccination program. And I'm sure putting in a plan like that in a third world country, in a developing country, had a lot of challenges and moving parts to really like make it all come together. Can you tell us what that process was like for you and your team?
Sure. So the first time I went to Mali, I went with my mentor, Dr. Mike Levine, who was the founder of the Center for Vaccine Development. And we went there and looked through the charts at the major children's hospital to see what illnesses the children were getting. And we found that over 70% of the children who were admitted to the hospital had evidence of having an infection. And about 20% of those children never made it out of the hospital. And most of them, when they, it was recognized that they had an infection and it was thought that they had malaria because it was a malaria endemic country. But they had no microbiology laboratory to be able to diagnose bacterial infections. And so my mentor had the vision to set up a microbiology laboratory in that hospital and look and see what kind of bacterial infections these children were getting that were causing what we call sepsis, which is when bacteria get in your blood, and meningitis, which is an infection of the brain and spinal column. And we set up that lab. We brought Malians to the US and trained them. We put them back in the lab and started getting some blood from each of the children who came in with this clinical appearance of a serious infection. And we found a huge burden of bacterial infections for which there were already licensed vaccines in this country. Hib, you may have heard of Hib, pneumococcus, meningococcus. And so we went to the president of the country and said, look, this is the information that we're finding. It's not that these children are all dying from malaria. They're dying from preventable infections. And he said, we need to introduce those infections. At about the same time, the Gates Foundation had contributed a huge amount of money to an organization that they formed called Gavi. And Gavi was developing methods to accelerate introduction of vaccines into developing countries. And so we use this information to apply to Gavi for vaccine development. And this was serially over a number of years. And one after the other, we helped to introduce vaccines and to strengthen the existing immunization system to be able to handle the new vaccines. And then we measured the impact, and you could see the reduction in hospitalizations, the reduction in deaths that resulted from introducing these vaccines, which was, for me, just a paradigm, life-changing event to see the impact that public health interventions such as vaccines can have on the health of children and the survival of children.
For those who are listening to this, describe what Hib is if they haven't heard about it.
So Hib, it's Haemophilus influenza type B. It's a vaccine that all children get routinely in the US. It's been introduced in the US for many decades. It was known as a major cause of sepsis, that is bloodstream infections, of meningitis, of something called epiglottitis infecting the throat, so children couldn't breathe. And when I was a pediatric resident, this was one of the most common causes of hospital admission, death, and disability for children. And we don't see it anymore because of the vaccine. And that vaccine had not been introduced into Mali. And because they didn't have the ability to make the diagnosis, they didn't even know what a big problem it was.
Wow. It's amazing. And talk about something introduced in the US and seeing cases go down. We don't typically think that a bacterial infection associated with diarrhea is going to lead to death in this country. So talk a little bit about, those rates that you had mentioned about how in sub-Saharan Africa and South Asia, there are highest mortalities from these diarrheal diseases.
So I do want to make clear when I talk about HIV and pneumococcus, they're not causes of diarrheal disease. They're causes of bloodstream infection and meningitis and pneumonia. But diarrheal disease is also one of the leading killers of children under 5. And some of the germs that cause it, like rotavirus, are germs that commonly infect children throughout the world. There are some researchers who call them democratic viruses because they don't select any particular population. But in the US, because of ready access to healthcare, all you have to do is prevent these kids from getting dehydrated. And so in the US, there were very few deaths before the vaccine was introduced in this country. But in developing countries, there are children who can't get to health centers and get life-saving fluids, and children who get, because they're small and malnourished, get dehydrated very quickly. And so they have a much higher mortality from these infections. And when we did our GEM study, we found that rotavirus was the leading infection. And we helped to do work to get the vaccine introduced into Mali and other African countries. And then we did a follow-on study to look at the impact of how that reduced mortality and dehydrating infections. There are other infections that we see in developing countries that we rarely see in the US. And also, if we do see them, children also recover pretty quickly. And so examples of those are, one is Shigella. It's the major cause of dysentery, which is bloody diarrhea. Children get much milder infections, and they're infected much less commonly in this country because it's spread from person to person where hygiene is insufficient. So when you have crowding and lack of good hygiene and sanitation in a developing country, Shigella is all over the place. And in the US, we see it in places where hygiene is compromised. So we'll see outbreaks in daycare centers or prisons, places like that. But because people's health is so much better, they recover from Shigella. And when children in developing countries get Shigella, they just can't recover from the intestinal injury. It's a very invasive bacteria, and they just don't bounce back the same way. And so they end up with worsened malnutrition or new onset malnutrition. And those cycles are very hard for children in developing countries to escape from. So they get one infection and their nutrition is compromised, and they're just starting to recover. They get another infection. And so they can never get back on track. And that can have very dire consequences.
Yeah, I was about to ask, you mentioned the vaccine program, and I'm sure it's helping those patients with that one infection, but with what you just described, are you seeing a lot of that where it's like, okay, we got this, one part taken care of, but now they're getting another disease because there's another, a gap in the system.
Yes. So, as a follow-up to the studies we did on diarrheal diseases, um, for my entire career spanning close to 40 years, I've been working on Shigella vaccines slowly with the grants that we can get, and it's been a very slow process. And when Shigella was demonstrated as such an important problem, really the Gates Foundation saw that. They've been funding a lot of these studies, and they have invested a lot of resources into accelerating Shigella vaccine development. And so that's one way, hopefully, one day there will be an effective vaccine that can prevent those infections. Something that I've been doing more recently in my career is rather than trying to fight infection by infection, to also try to look at interventions that are agnostic to the specific germ and maybe just improve child survival. So I'm involved in two studies. One is called CHAMPS, and that's a study whose aim it is to understand better why children under 5 are dying. Because when you don't have good healthcare and access to diagnostics, you don't often know why these children are dying. You can only kind of put the symptoms together retrospectively from what people call verbal autopsies, which are post-mortem interviews. That's how a lot of information of the causes of death had been acquired. The CHAMP study actually asked parents if they would be willing to allow their children after death to have needle biopsies. So just taking a small needle and putting it in different tissues, and then looking at those tissues for the pathology and the infections that may have caused their demise. And so that is one way of just kind of looking globally and trying to prioritize what the causes of death are. And then there's another fascinating field that I've had the opportunity to become involved in. And that is the use of the antibiotic azithromycin to prevent infant mortality. So there was a discovery by these very smart eye doctors, ophthalmologists, who were trying to eradicate the major infectious cause of blindness in Africa, which is called trachoma, with azithromycin. And they were doing mass campaigns where they would give everybody a dose of azithromycin, and they had control groups to see if it was working. And they noticed that the children in the control groups were dying at a higher rate. And they made this really incisive observation that for some reason the azithromycin was preventing these children from dying. And so they turned and did a study that was called MORDOR, where every 6 months they gave children under 5 a single dose of azithromycin, and then in other villages they gave those children placebo. And they actually showed that this was in 3 countries in Africa. They showed that overall there was about a 15% reduction in under 5 mortality, and in the youngest children it was a 25% reduction in mortality. There's nothing that does that, has that kind of impact. And so we were asked again by the Gates Foundation whether we would be willing to do a different approach with the same drug, and that is to give it to pregnant women and children, just a single dose 3 times during pregnancy, and then with the first and third baby shot, and see if you give it programmatically, so you don't have to go take a whole team and go village to village, but just when either the moms come in for antenatal care or the kids come in for their routine vaccinations, they get a dose of oral azithromycin, and see if you can have the same impact. So we're doing that study. We have 40,000 pregnant women enrolled and their children in Mali. Our aim is 50,000. So we're going to finish this in early 2023 and understand how if that's an effective approach. And that's, I pray that it's going to work and that it will have an impact, a big impact, and biting my nails until we get the results.
That's amazing participation.
Yeah, it is.
Wow, that's incredible. Are there any downsides to those doses of azithromycin?
It's a very safe antibiotic, and we're following safety very, very carefully. And so, with the ability to compare safety events between women and children who get the azithromycin and those who don't, we'll be able to take a very close look at safety. The only known effect is that there's a swelling of the stomach that can occur when young babies are given azithromycin or erythromycin, and that can sometimes cause an obstruction that needs to be relieved. And so that is a precaution. The drug is still used when it needs to be, when the benefit far outweighs the risk. We have seen one case of that. The baby did fine. But we don't know if that baby got azithromycin or placebo. And it's a condition that also occurs normally in that same age group. So it's quite possible that the baby had gotten placebo. We don't know. And that's the only rare side effect that we anticipate that could happen. I mean, there can be allergies to any antibiotic, but we really haven't seen any serious allergic reaction.
That's great. Really incredible news and outcomes. I want to back up just for a quick second. You mentioned those light touch autopsies. I'm just curious, like culturally, how do the parents receive that request? Is that something that seems completely foreign to them, or because it's just such a light touch, they're not really bothered? Just culturally.
That's a great question. And we're conducting this study in Mali, which is a largely Muslim country. And so we also felt that it was very important to understand the religious implications of what we were doing, in addition to introducing something that's quite new culturally. To a country where surviving and doing research to help people survive is what's perceived as the priority, not studying children who didn't survive. So it was a change in mindset, and we began the study with several months of doing social behavioral research. SBS is what we call it. And so there were Malian anthropologists and behavioral scientists who helped us, and we had focus groups, and we explained the reason for the research to these people from all walks of life, and got lots of responses and feedback how they perceived this work. And we tried to explain our perspective. And this is an ongoing process. So it took, it takes a lot of work for it to be accepted as something that has potential benefit. But it is, it's not accepted by everyone, and we completely understand that. But we're getting a lot of important information out of this study. It's happening in 9 sites now throughout the world, sites with high mortality, and we're learning a lot. For example, in Ethiopia, we learned that there was a much higher frequency of babies being born with malformations of their brain and spinal cord. and it was related to mothers not getting enough folate during their pregnancy. And so we do data to action. When we discover that there are events that are occurring that are leading to mortality, we try to develop an intervention to end that. And so we're also hoping that people will understand the value by seeing that data to action.
I have another little just people-centric question. So how does it tangibly work? You know, you've done all this research. It seems like you're onto a lot of great ideas of how to combat some of these illnesses, getting vaccines out. But in these rural areas, are you just kind of like Wizard of Oz in your wagon traveling from village to village? Or is there some systematic way of distributing the vaccines and the azithromycin?
So it depends on what phase you're in. When you're doing research, research is a very intentional, carefully organized, with huge amounts of oversight event, very well controlled in a circumscribed population where you're following a protocol exactly. And so once you get those results and you can trust them because you've conducted the work as meticulously as you can, then comes the intervention. And so for vaccines, throughout the world, including developing countries, there's something called the expanded program for immunization. And these are programs that were set up in the 1980s to distribute vaccines equitably. So that's when people say vaccines are one of the most equitable health interventions. That's because you can set up little rural health posts. There are vaccines that are introduced with people with cold boxes, on donkeys, on bicycles. And there is a countrywide plan to maintain a cold chain and distribute vaccines. And so when you introduce a new vaccine, you have to appreciate the impact that it has on that system and account for that and do the appropriate training to be able to safely get vaccines that are still in mint condition out to rural areas. For azithromycin, we're still in the investigative phase. And so we're working in 82 health centers in rural Mali with, our team is running the entire study. We have hundreds of people who are trained and employed in doing this and very careful oversight. And then there will be an implementation phase. And that will either be done through existing antenatal care and the infant immunization program, if that works, or door-to-door giving out mass drug administration, the way the eye doctors try to eradicate trachoma. So we'll have to see the results of these studies before we understand how to distribute the vaccine. And then the infrastructure, the drug, azithromycin in this case, acts like a vaccine because it's preventive. But there has to be an infrastructure that distributes the drug safely and effectively.
It's like starting from square one with logistics, and that goes for, as you said, just not just the infrastructure and logistics of delivering healthcare, but just the infrastructure period to get some of that medicine or anything really delivered in those remote areas.
The devil is in the details. If you break the cold chain or let vaccines expire, then there's no reason to give those vaccines, so you need to pay careful attention to all those details.
Right. And, as we've been talking about, a lot of your work centers around global health throughout your career, and specifically children and giving children a chance to live. I'm sure you'll talk about your education and everything that led you to this career, but I was wondering if there was anything maybe as a child yourself, if something you watched or read that maybe sparked that imagination and pursuit of eventually getting to where you are today?
That's a tough question. My dad was a general practitioner with a black bag who made house calls. And I would go with him on house calls. I would wait in the car because he didn't want to impose me on anybody, but somehow still that was fun. I think because we got ice cream at the end.
Bribing you with ice cream.
Yeah.
Exactly.
Little did he know that it would inspire you.
Yep, get a long way with an ice cream cone. And then I was always like the kind of child who liked to help people. I mean, I was going door to door collecting for charity and volunteering from a very young age. So that was something that fascinated me. And also, I learned that I was fascinated with other cultures and traveling to other places and just kind of understanding what people's lives are like that are different, from me. I don't know, that just always intrigued me. I wasn't one of these. I mean, there are people who, they're 5 years old and they know they want to be a doctor and go into global health. I kind of accidentally meandered into my field. And then when I hit the Center for Vaccine Development, for me, it was like being a kid in a candy shop or maybe in an ice cream store. I just watched what they were doing, and no one had ever told me you could do that when you were a doctor. And it just was, amazing to me. And so it's hard to know what about me made me glom onto that, but it just captured my imagination and I wanted to do it. And so I did it.
Yeah, it would have been great if your dad did take you with you to the patients and he would joke, well, this is my physician's assistant. And see the look on their face.
Right. She's a child doctor.
Just
which is what I am now.
Oh, it all comes full circle.
Really?
No, we've been calling you Dr. Kotloff, but you also have another title. You were knighted by the government of Mali, which is incredible. Can you tell us a little bit about that story?
Sure. So me and my mentor, Mike Levine, after we did that research that we presented to the president of Mali, and he decided that he wanted to introduce the Hib vaccine, he decided to make us chevalier. Mali is a previous French colony, so that's what a knight is in French. It was quite a surprise. I had never heard of a chevalier prior to that. It didn't come with a white horse. But a chevalier means a horse rider in French. So that's why I'm saying that. It did not come with a white horse. But anyway, they gave us an award for doing that.
That's awesome. So like we're basically talking to royalty a little bit.
She can use that when she runs into Sir Paul McCartney.
Right.
Right. I'm not sure he'd be all that impressed, but I did go to see him this year.
Oh, fun. Well, I'm very impressed with all that you and your team are doing, Dr. Kotloff. Thank you so much for joining us today and being with us and sharing all of your great information.
We did say that you are in the middle of still doing this thromycin program, which is still in the works and is not going to be completed until sometime next year. So how can people stay up to date on that research that you're working on, or when can they expect to see the results of that? Because, you have a lot of participants involved.
We'll complete enrollment in the first quarter of 2023, and then we'll complete follow-up because we have to see how the children do. And the enrollment is the pregnant women a year later. So the results will be released in 2024. I assume there'll be some kind of press release when the publication starts to come out or the results come out. So you'll have to check back.
Our intrepid staff in the communications for School of Medicine and CVD will be sure to tout that all over the world.
Yep, I bet. I
Yep.
bet they will.
Yeah. So
And hopefully there'll be really good results.
absolutely.
Fingers crossed.
Yeah, so thank you so much, Dr. Kotloff.
Sure. Thank you.
The UMB Pulse will start a new season in 2023 focusing on alumni changemakers. Our first guest in January will be Catherine Pollock. Catherine is a graduate of the University of Maryland School of Dentistry who returns to the school each year to operate a dentistry camp she founded called Planet Smiles. We will learn what led her to start Planet Smiles and how her grandfather's survival in a World War II concentration camp inspired her to become a dentist to improve the oral health of children. Subscribe, rate, and review the UMB Pulse on Apple, Spotify, and wherever you like to listen to get an alert for when our next episode drops. Feel free to reach out to us with your questions by emailing umbpulse@umaryland.edu or visit our website where you can listen to past episodes and contact us there as well at umaryland.edu/pulse. Enjoy the holiday break, everybody. We will see you in the new year, and thank you for listening to the UMB Pulse.
UMB Pulse with Charles Chalet, Dana Rampolla, and Jenna Frick is a UMB Office of Communications and Public Affairs production. Edited by Charles Chalet, sound engineering by Jenna Frick, marketing by Dana Rampolla.